I'll just do it that way. So just some brief disclosures. Myself and John are on the board for AGM, and Marquita is the president for ADIM, and Samantha is CEO for Medical Legal Partners of Boston, but no financial conflicts. So the main objective is to describe the three main categories of social determinants of health, amenable for health system intervention, and the main screeners as it pertains to the emergency department and older adults. We're going to describe the financial, legal, and social services available for older adults from the ED and the variability in access to these services. And lastly, we'll discuss novel interventions with older adult ED patients that have been proven efficacious in the ED setting. So we're just going to start off briefly with a case. So chief complaint of weakness, my least favorite complaint. This is a 70-year-old female with a history of diabetes, arthritis, high blood pressure, and prior alcoholism. Comes to the emergency department with generalized weakness and bilateral leg pain and swelling. Symptoms have been getting progressively worse over the past 3 weeks. Called the ambulance because she had significant pain on the ambulation despite using her walker. She arrives primarily to get some new prescriptions and is asking for a tray of food. So review system's pretty unremarkable. Meds, some hydrochlorothiazide, metformin, Tylenol. Vitals on triage, she's a little hypertensive, a little tacky, finger stick is 350. Exams notable for some dry mucous membranes and some lower extremity edema extending to her calves. So we do a typical weakness workup. Labs notable for elevated sugar, Miles gap of 16. I'm just going to use this thing. It's fine. Yeah, it's fine. It doesn't really matter. Chest x-ray is fine. She looks like she's got a UTI. So if patient's given some IV fluids, improvement of her glucose and her anion gap, given some antibiotics, some ibuprofen for pain, and her home hydrochlorothiazide. The pharmacy's call looks like she's got prescriptions available for the patient for that's been available there for the past month. She just hasn't gone to get them. And they disclosed to discharge her after she feels better. She's given prescriptions for antibiotics and a short course of ibuprofen. But, of course, there's a hiccup. So on further discussion, the patient tells you that she's been unable to pick up her prescription medications or go to any of her appointments because she's on a third-floor walk-up. With difficulty walking down because of her arthritis and the fact that she uses a walker, she's 2 blocks away from the nearest bus stop. She's recently homeless after her landlord evicted her for unclear reasons, now staying with an acquaintance on this third-floor walk-up. She's got no family supports because of her alcoholism. She doesn't want to go to the shelters because her stuff was stolen there. And she's trying to remain sober, but feels it's quite difficult due to her current living situation, and she's afraid that the person she's staying with is actually taking her Social Security money. So I feel like this situation is something that we often come across as always a hiccup in the DISPO plan. And it's interesting because this whole piece of the social situation technically should have been taken in the beginning with our usual HPI, but due to like normal ED constraints, we often skip some of the stuff. But when you find out all this stuff, it brings you to this great aha moment. This is what led her to come to the emergency department today and all the stuff that's brought her to come to this point where she had nowhere else to go except for the emergency department. And with that, I'm going to pass the baton off to John to talk a little more.
Thanks. So we're going to rewind the case a little bit. I want to go back to this case, and I want to invite you to think about your last shift or the last month, and which case in your mind does this remind you of? So again, think back to your own hospital. Have you seen this case? What does it remind you of? So hold that in your mind as we then go forward. And we want to introduce this concept of social dimensions of health. And the material, the psychosocial, and the behavioral are 3 domains that you can put social dimensions of health into. I also want to let you know that there are a number of ways to conceptualize social dimensions of health. This is one I like, has 7 domains here. So again, if you look at the material, you can see housing, transportation, economic. Those kind of go in that material basket. Psychosocial, we're looking at health literacy, social support, crime and violence, so you can see those there. This particular one doesn't have behavioral on here, but those are things like addictions and health behaviors, not adherence. So again, this is one way. Again, you'll come across many of these. So again, if you're confused, you're like, somebody's saying this, I'm validating that for you and saying, yes, there are many of them. Here's just one way to reduce it to 6. The Kaiser has, these are another 6 domains. I like this chart. It lists some of the specific things that fall in those domains. So again, economic stability, neighborhoods, education, food, community, and social context, healthcare systems. Again, these are all different social dimensions, health domains there. They also then lead to the health outcomes. So that's kind of where our focus is and how do these affect health outcomes. So again, this is Kaiser, who's doing this work. And then I want to have the take-home message that there's really robust activity in this area of social domains, social determinants of health. So again, you see here the national academies have done work in this. They have 17 different domains and subdomains, so a lot there. ASEP has the social emergency medicine section. They had an Inventing Social Emergency Medicine Consensus Conference in September 17. I have neglected to put SAEM has an interest group on social emergency medicine and population health. They are meeting tomorrow morning at 8 a.m. Again, if you have an interest in this topic, I encourage you to go to that session tomorrow morning to get together with like-minded people here in SAEM. There is the Social Intervention Research and Evaluation Network at UCSF. Stanford has work going on. UCLA, Boston. So again, a lot of robust activity in this area. There's also age-friendly healthcare systems. CMMI, the Center for Medicare and Medicaid Innovation. Again, lots of resources out there for us to look at. You don't have to reinvent the wheel. So the question, to screen or not? So in your ED, people may say, why are we to screen? We can't do anything, it's overwhelming, it's going to take too much time. And then if you do have a positive screen, what do we do? Right? So to screen or not to screen, I want to introduce one tool. Again, there's bunches of tools out there. There's also groups that are synthesizing those tools, looking across tools. This is one that I came across that I think is relevant for the ED setting. It's a yes-no. So many of the social determinants of health will be very expansive. We'll have multiple categories. This one I like. It's 10 questions. Has a yes-no. And again, this is patient self-report, so they can fill this out on their own. You can see the domains listed here in terms of the first one in terms of money or food. Housing stability, again, more housing stability in the third one. This one talks about childcare, which may not be relevant to older adults, although it could be if you're a grandparent taking care of grandchildren. Looking at healthcare access in terms of cost. Next 5 questions have to do with transportation, health literacy, social environment, and then asking those questions, do you have an urgent need and do you want help? So again, I think this is a fairly concise measure. You may not need to do all these questions. The other take-home message I'd like you to think about is what's important, what's the pain point in your local hospital, in your local environment? Is it housing? Is it food? You don't have to do all these. You can just pick 1 or 2 and say this is the one we're going to focus on. So again, this is an example from the Health Leads Project. That's where this comes from. But again, many measures out there in terms of social determinants of health. And then connecting this to research. So we asked this question, and then what does the research say? So I picked a couple domains here in terms of food, in terms of housing, in terms of social issues. And there is research that's supporting, when you ask these questions, connect them with resources that can have an impact on our important health outcomes. So with that, I'm going to leave that with you, the screening part, and then pass it off to my colleague to say then what happens once you screen and identify one of these issues, and we'll go from there.
Hi, everyone. I'm Samantha Morton. It is true I am a lawyer, and I'm hopefully one of the good ones from your vantage point. I actually feel quite a kinship with you in this room and at this conference, because when I started my public interest law practice 16 years ago, I came to understand that what I was doing was actually, in effect, a legal emergency room practice. Pediatricians at Boston Medical Center would page me and my colleagues, we did carry pagers at the time, and say that it was my job to, could I please represent Mrs. Alvarez in her deportation hearing tomorrow, and could I represent the Smith family in their eviction case in housing court next week. And it was my privilege and pleasure to do that for a number of years, in particular on behalf of Haitian survivors of domestic violence. So that is the legal emergency room context that got me some level of entry to your fascinating conference today. While I am not a capital R researcher, we can talk over wine sometime about whether law school is doing its job in terms of things being data-driven and evaluation-focused. But I can tell you that I signed my organization, the Founding Medical Legal Partnership in the United States, up for 5 rigorous research and evaluation projects. And I'm still waiting for forgiveness from my team of public interest lawyers, because there was no big research apparatus that came with it. However, boy, have we learned a lot about testing what works, admitting what doesn't, and then making adaptations. I share that with you because if you haven't noticed, my presentation style today may be a little bit different, maybe a little bit folksier, maybe a little bit less precise. But as you absorb these sobering statistics about older adults served in your emergency departments, I just want to offer the preview of anecdotal evidence we're going to get to by the end of our presentation today, which is that many institutions, many health systems, including perhaps some that employ you or with which you're affiliated, are so convinced that focusing on older adults' social dimensions of health is important that they are actually funding more people like my team to join the care team. And so, again, that is what inspires me and what makes me just so pleased to be here today. So I'm not going to focus on reciting a bunch of statistics that hopefully aren't news to you, in the sense that there's a lot actually that is now understood in mainstream society about the vulnerability of people living in poverty, many of whom are older adults, regardless of how the age metric is measured. And what I would like to share, which I hope, which may or may not be intuitive, I should say, is that at the federal and state level, among people living in poverty, older adults are entitled, under a range of laws, policies, and regulations, including the Older Americans Act, and a host of civil rights legislation that actually identifies age, and specifically older age, as a protected class. That is a term of art in my world. There are a lot of protections for people to make sure that they have better odds of being and staying healthy. So I want to ask you, because this is just how people like me roll when we're in conferences, and I hope you bend to me a little bit. Can someone share, and can a few of you share some examples from your practice when you've tried to connect a patient, or someone on your team has tried to connect a patient to one of the resources that you see on this slide, and what happened? Or or a resource that you didn't see on this slide. Professionally, what's at stake here is so low with me, right? I mean, it's just the public interest lawyer who's the guest at this conference. Don't let me be the lawyer who bombs. Someone give me, thank you, thank you.
One of the challenges with the emergency department is we don't know people refer people, we don't get the feedback.
Makes so much sense. But can you think of something that you thought was happening for a patient of yours? Right. makes so much sense. Thanks to you. Kalpana?
No, just wanted to remind everybody to speak into the mic because they're recording, I guess.
Oh, yes. It is my job to repeat your questions and probably now your answers. So thank you very much. Thanks to you both, by the way. Thanks for reminding me what I actually knew, what was an attribute of my practice as well when it was a legal emergency room. And you guys aren't getting, it's not part of your practice to be doing root cause analysis and then go figure out all the different, failed steps. However, there's more energy focused on that. That's really part of what our point in our sort of mission, if you will, here today is. I guess I'm curious, if I were you listening to this, I'd be saying, who's my social health team that I can turn to when people have these needs? And I'm just curious, because it's not like your time is about to double. So I'm just curious, does anybody work in an emergency department setting where there are staff that actually are charged with this? Yes. (24/7), 2 social workers. Where are you based? California. Where in California? Sacramento. Go Sacramento. Okay. And I heard clinical care coordinator. Right. You probably could triple that and you'd still be needing more. Anybody else? Anybody else have staffing innovation or staffing woes they want to share before we continue? All right. Well, thank you. So I'm curious, when we think about barriers facing older adults that are different, some of the barriers that you see here, particularly poor access to transportation, which depending on geography, rurality, and all sorts, and certainly income level, frankly, as well as domestic violence and elder abuse, where abusers so control people's access to transportation resources. I'm wondering if any of you have come across other barriers confronting older adults in your practices in terms of accessing supports when you or a member of your care team was trying to provide assistance or connectivity. Go ahead.
I think that there's oftentimes older adults have a healthy degree of skepticism, and so it's the establishment of a rapport coming from the emergency department.
Mm-hmm.
I've seen you once, I've got this team who's seen you once, and maybe somebody else is going to be one to try and follow up. Is this person who is vulnerable and potentially isolated going to open the door?
Going to open the door.
If
Yeah.
you have a home care coming, or
I see.
you have services that are reaching out,
Yes. Yeah.
you be willing to accept those services.
Sure. And is there going to be trust and comfort and actually making a connection between that person at the door as opposed to the person who they encountered in the ED, even if they say, I was sent by Dr. Smith? That's really helpful. Have you seen that be a problem?
Yes.
Okay. Anybody else? Okay. Well, let me just say that while in the legal world, legal scholarship establishes that it's very rare for a person to wake up, get an eviction notice, and then say, whoa, I have a legal need. No, no, no. I have a housing problem, right? So setting that aside, that we actually have some really good evidence in the legal community that one's perception of what kind of need one has really often bears no relation to how our professional norms and jargons characterize needs. In any event, just sharing with you here that older adults will experience kinds of legal needs that bear similarity to people across the age and health continuum, for sure, but also very different and unique kinds of needs. And I am glad to say that in several of these contexts, there are unique protections for older adults by virtue of civil rights laws and disability laws. And we will come back to our original hypothetical in case study later. I'm just curious, before I pass it off to my valued colleague, has anyone treated someone who had one of these challenges? Whether you knew it was legal or not, or whether you knew it could have legal dimensions or not. all the time, every day. Any notable stories? So what's working? In your setting, where do you feel the most confident connecting someone to resources in your community? Uh-huh. Okay. That's okay, but I really did hear, thank you, Alex, for that commentary, that things in your experience as a practitioner changed, and you believe also for patients when social work resources were infused. Thank you, sir, for going to the microphone so gracefully as 5 people left while the lawyer was talking. Go right ahead, and then I really am passing it off.
I'll be brief. My name is Marquita Hicks. I'm at Northwestern University with Alex and Scott, and I agree with Alex's point. 24/7 social work is great. They're human beings, and so our confidence in the process is only as good as our confidence in them. And we've been lucky and fortunate to have very effective but also humanistic social workers.
Mm-hmm.
To the point where when we refer a case to them and they spend 2 hours digging into that case and they come back to us and they say, you know what, I've tried X, 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 Y, and Z, and it isn't going to work. This person, you know what, I feel like everything's been done. On the other hand, when they say, I've explored X, Y, and Z, and this is what we're going to do, this is what we're going to do, I feel a little confident. But we have a lot of patients who are homeless for the most part in a geriatric age group and resistant to a lot of efforts to reconnect them.
Mm-hmm.
Some of them have lost identification, which is a humongous diagnostic barrier for them to seek access.
Mm-hmm.
But what's really nice is the quality of social workers. We put a lot of trust in them to the point where we hand it off and we're kind of out. For good or bad, and that's kind of the nature of it.
Sounds like, thank you for that, and sounds like we're going to be coming back to this question of team-based care in the ED very soon. Someone in the back, yeah.
Hi.
Hi.
So I practice in the center of the universe, New York.
Okay. I buy it.
And it's really interesting to me, after doing this for a little while, the mismatch between our 24/7 operation and the 6 hours a day, 5 days a week that we interface with on many of the long-term social and housing services. And so what happens to us on Friday at 3:30 is we're looking at patients who have a 3-day stay somewhere, and show me by show of hands how many ED docs can place one of those patients in the hospital on Friday afternoon. You can't.
Mm-hmm.
They're 3 days in a stretcher that has a mattress that's about an inch thin. They're already at risk for bed sores. If they don't have ICU psychosis by the time they get to us, they will by Monday morning. And we're making things worse. So there's really no recognition that these people, and they're pejorative terms for relatives sent to the ED on Friday afternoon, and I won't use them because I think they're representative of real social problems and shouldn't be made fun of, but they do happen. And we don't have services that match our patient arrival peaks.
Thank you for that. Here, and if I haven't burned too much time, if I'm allowed back to the microphone, I'll tell you why I'm not a legal emergency room practitioner anymore. Although I think it's great that you all are emergency practitioners. I'll be back.
I felt like you read some of my slides ahead of time. So as we know, as we start having an older, population, our demographics looks older. The caregivers involved with these patients are also of significant importance. And so, what happens to these caregivers? I mean, they're tired. They are absolutely tired. They are under a lot of physical stress, mental stress, emotional stress. It's leading to fatigue, eating disturbances. When do they have time to take care of themselves? And as our patients are older, our caregivers are also a lot of times elders being partners, spouses of these patients, or even children. I mean, you know, my personal experience is I have a 93-year-old grandfather and an 89-year-old grandmother with dementia. My mother is around 70. She's at the age where I'm trying to think about her and her health and things like that. And so how to manage all of that. And who knows if that older caregiver is also taking care of a younger child in the home in this day and age where we have, you know, an intergenerational component of grandparents taking care of grandchildren and adult children living in the homes. So it becomes very complex in this burden. And so this ultimately leads to, you know, negative effects on the health-related quality of life. Predictions of this caregiver burden is depression and disability of the patient. If patients aren't able to at least move around, this is going to put more stress and strain on that caregiver's body. Feelings of hopelessness, social isolation, all their time is given to the patient. And this can be with older caregivers or younger caregivers, because there are plenty of grandchildren taking care of grandparents right now. And also financial status of our caregivers. If caregivers aren't able to work because they're having to take care of our older population, this also becomes a strain on the family and their work status and their sense of well-being. So, you know, they ultimately have a lower health-related quality of life. And so I want to put out there during this research, there is not a lot of information out there. There is so little information out there that I felt like I was like, am I pulling at straws here? Because, I mean, I felt like it was just ripe for an organization like us to kind of figure out what can be done and what can we do to at least learn more about this. Also, there's not a lot about cultural differences as it relates to this area. And we all are aware that, as already been mentioned, there's a lot of distrust based off of various cultural, you know, experiences. And so how does that play into accepting help, as I think Dr. Cordy mentioned, into the home, or, you know, and things like that. So also, you know, decreased finances in the home can lead to economic strain and increased depression. So, I mean, as you mentioned, we were talking about ED resources, and I was thinking, well, what kind of resources do we have? Because at my previous institution, we did not have 24-hour social work. It was a 8 to 5 and sometimes 8 to 10. I think that was my later years there. But, you know, 24-hour social worker is huge. You know, how many patients do you know, old or young, come to the hospital just to get a meal? And I honestly don't know how to access like Meals on Wheels from the ED if I have an older patient with a food insecurity issue. And I thought about, you know, in my, 12 years of practice, have I referred a patient or a family to a senior citizen center or provided them information about a senior citizen center? Because I couldn't think of a time that I had done that, but that could be a huge resource for their family if they're like on the cusp, just needing a little bit of assistance. So, just thinking about what we have access to right now, and what are some ways that we can improve as ED physicians. So Dr. LaMantia and Platts-Mill wrote in, and this was a geriatrics, I think, editorial, that characteristics of successful geriatric interventions include screening or assessment instruments to identify needs, as well as connecting the patient to community resources to provide further evaluation as well as close follow-up. And we've already talked about how a lot of times we don't know what the result of that is, and that becomes very difficult because then you end up seeing the patient again, and you're like, well, what happened the last time? I thought we had given you resources. And so I was tasked with trying to find some interventions. And let me tell you, it was hard. Okay? So there were a couple papers by some great geriatric emergency physicians out of this organization. So the Geriatric Emergency Department Innovations in Care through Workforce, Informatics, and Structural Enhancements, or GDWIS. It's a model of geriatric emergency care in 3 large urban hospitals, Mount Sinai, St. Joseph's Regional, and Northwestern. It's an ED-based transitional care nurse program that identifies the patients and their needs and then coordinates their transition from ED to home. Now, each of these centers did it kind of their way, what works for them, because as you know, what works for my shop might not work for yours. So there has to be some level of individuality. But what they did learn was that the risk of admission reduced for these patients that these transitional nurses were involved with 5 to 16%. So the risk was reduced by the range of 5 to 16%. And it was a unique approach to averting inpatient admissions. So Northwestern wrote a little bit more about theirs in their geriatric nurse liaison program, in which they identified older adults through screening. And they did follow-up phone calls. One phone call was 24 to 48 hours, and the other phone call was about 10 to 14 days after discharge. What they learned was that that first phone call was a time to really address the complaint that the patient came into the emergency department with the first time. And also medical equipment. How many times have the patient left you thinking that the oxygen's going to be delivered or something's going to be delivered at the house, and then come to find out, you come back the next day and you're like, wait a minute, I discharged that patient. What happened? Yeah, it didn't get delivered. Something fell through the cracks. And so this phone call would address that. They found out that later time point did have added value, though, because they were able to address some subacute issues that may be there, some additional medical equipment issues, and also some transitions to care, maybe getting them into primary care if they were having some difficulties with that. So there was added value to these follow-ups. I will say on this, I think, and it was actually mentioned in the article, that one of the key components of this was that we were using geriatric trained non-physician providers to assist in kind of helping with this plan and with these transitions of care. And so maybe that's an approach that could be thought about further as we work to find solutions to this complex situation. Yes, ma'am.
So I'm at the University of Wisconsin. We've been working on a community paramedicine program along with our colleagues at the University of Rochester to do exactly that. And as we are starting to tailor and develop it more, we're starting to try and also take more of an upstream approach, partnering with primary care, so that it isn't so siloed, so that information about some of these social determinants of health can be fed across from primary care to home health to emergency care, and so that we can also keep track of some of those resources, some of the senior care centers, memory care, especially around patients with dementia and their caregivers, ways of connecting them with educational resources so that they can take care of themselves, to connect them with respite, which is a big driver of caregivers bringing family members with dementia into the emergency room. So we're trying to take that non-ED physician approach to bringing that connection out into the community.
Yes.
And prevent some of those visits from occurring, or at least those revisits.
So making it more about community-based care and a team. I mean, it's what we're talking about, being a team and a team approach with the patient, the community, and the family, and the primary care provider in order to address all these issues. I think that I will. Oh, I'm sorry. Is there another comment? Real quick. Oh, yes, ma'am. I think he's bringing you a mic.
I think in Sheffield, called Discharge to Assess, where instead of assessing people,
discharge them, and then send physical therapy or case management to the home and assess them in the home. It improves mobility, but also gives them that added benefit of looking at the home setting and identifying additional barriers as well as addressing what you're sort of talking there about, looking at medication and discharge instructions.
And he's bringing the mic to you, because we're recording, so they really want us to use the mic.
I'm Scott Dresden at Northwestern. I appreciate you highlighting our work. So my question for you is, you have dug through all of the literature that's out there, and we know that it's not much. We have our own ideas of where we want to continue to go with our programs, but you tell me. Like, you guys are the experts on this right now. What should we be doing? What is the research that needs to be out there, to better understand this problem?
So, well, okay, I will, in full disclosure, I do not feel like the expert in this particular area. There's a lot of family experience that I have, especially recently, but I do recognize, and as I mentioned, that there is, as we are continuing to do this research, we definitely need to think about the component that race, ethnicity, cultural differences have in it, because because one size won't fit all. This is we are a very diverse country, and we at least need to broaden our research to be respectful of that fact. And so that's where I would definitely say that, if you're doing a study and you include, all Caucasian males, then you're missing a good portion of the population, and so with our changing demographics, we need to be able to say that this research at least will touch on or will be able to be utilized by a good portion of the people. That's where I would take that. Do you have any thoughts on that?
So I think, can you hear me? Yeah. So I think for the research piece of it, I mean, it's interesting. I think this is great that it's followed the talk that Tim had just given about like what exactly is value-based care, because I think this is a huge opportunity to define what that is, especially with the social determinants of health. I mean, we understand that the key piece of all of this is making those community connections and that transitions of care and affecting quality of life. And I think that we have the opportunity to really shape what that is for the older adult when we really attach value, like what we define as value for the outcome, specifically attached for the social determinants. What I've also found that is attractive for hospital systems is attracting, putting it in the perspective of things that they care about, which is ED utilization, revisits, and just total costs of care. And at least with the program that I'm heading up, you do find decreased cost of care. You do find decreased ED utilization. I think it's just the way that you frame all that data to present to them to make a case for why these services should be in place, that this is really driving at some of the population health that we try to manage from the emergency department. I think that there is also, it's important to understand that engagement for this patient population is tough. I know that there's pretty significant case management programs that are out there that have these huge retention rates, but those are people, in my opinion, who actually show up to clinic. And the ones that we see are the ones who are not even making it to clinic and trying to figure out how that engagement piece. And I think that doing stuff like, you discharge the patient and you try to visit them at the home, but at least in my hospital, half of them don't have homes. So where are you visiting them? Where are you going to meet them? And if you're not able to solve those problems within the next week or two, they're quick to fall off your radar because they have other priorities just to keep themselves alive. So I would say that there's a huge area that we can think about to move the research forward. I think the field is wide open, but these are a lot of the struggles that at least I face with the programs that we're trying to do for our social determinants of health.
Scott, I jump in also. So when you look at the screening tools, there's so many domains and so many people doing so many different things. But I would turn it back to the local setting to say, what is important to us? And pick out what it is that's important to you that you see, again, as that pain point. And you can really run with that because, again, there's just not a lot of data out there. So there's the kind of national guidelines from the National Academies of Science. So you can kind of have a backstop there to say, hey, here's these domains that are out there that are listed by the national organization. We're going to run with this one. And I think go with what your passion is or the pain point at your local place. We heard about the EMS paramedicine. So again, if that's your area, go with that. Don't worry about doing the 17 domains.
Just to transition to our last section, I think, of our presentation, and to build on the question and the answers supplied so far, I want to just echo what Marquita shared about the need for not just linguistically, but culturally tailored and culturally brokered services. I know that we're all familiar with that at a high level, but certainly in the public interest law community, when we try to partner with colleagues like you, these challenges only get exponentially made harder if we aren't all marching in lockstep forward together on that. I also would just say that in our experience, this question of paramedicine that you brought up from Wisconsin, and by the way, you had me at the word upstream. Thank you very much. That's, I think the real charter here is creating more continuity and more upstream interventions and relationships. What we have had an opportunity to do as our organization stepped away from being practitioners in a legal emergency room was not to walk away from emergency rooms as places of great need that merit support, but to actually partner with our moderator and her co-PI, Patricia Mitchell, who's sitting there to my left, on a really exquisitely designed project funded by the Health Policy Commission in Massachusetts, and which is focused on high-need, high-cost patients, to use a phrase that I know is, the term to decade, but so dehumanizing. In this case, our patients have all been admitted more than 4 times in a defined period. To their great credit, Boston Medical Center's emergency department is integrating community health workers to systematically screen people for not just clinical and behavioral health needs, but also social dimensions of health across a very rigorous screening tool. They are providing support as patients wish who become enrolled in this project, both at the ED, on the hospital campus, and at home or in the community. And we have piloted an interdisciplinary team meeting that includes not only members of the clinical team, but also all the community health workers and a member of our legal team, so that we are lawyers supporting emergency room treatment, but we are operating in a more upstream posture that is not about going to court for patients, although, just to build on your advice, Kalpana, in this accountable care environment and given the level of need that's on display and getting worse, we actually, as an organization, have subcontracted with a plaintiff side housing lawyer to provide value-based legal care. In other words, we pay this wonderful lawyer up front a fixed capitated rate, and what he is joining us in risk sharing. He is joining an ACO, in fact, in risk sharing, because he may get all 10 cases in February, and that's his problem. And he's got to figure out how to do the legal work in a high-quality way. That is very unusual in the legal setting, and it's the kind of innovation that this project is making possible. I would also just encourage you, the slides that I shared include data that's drawn from this report. That's also, the link is embedded in the materials that I know you'll have access to. And if you're looking for research ideas, if you're looking for inspiration around social or legal intervention innovations, this brief is chock full of ideas, and I really encourage you to check it out. I'll stop there.
So I don't know if Samantha specifically talked about this, but this is a bunch of projects that legal was involved in, and feel free to, just for the sake of time, to chat with her about them specifically after the talk. So just quick case rewind. Fortunately, this patient was at a great academic center where she screened positive for housing, food, safety, some social supports, and some potentially legal supports. Some referrals were made to social work, referrals for food banks, some sobriety programs, and the PCP was called about ongoing housing supports and elder advocacy. Now, I realize this is an ideal outcome for a patient, and we all work in a very constrained ED environment where not all of this is clearly possible, but I think that we have to think about ways to help our patients and really think about how we can think outside the box to improve their health, and not just targeted through medical care alone. So just in conclusion, social determinants of health is an important topic for us to screen for older adults. It can be feasible when deployed appropriately. There are interventions that can demonstrate a positive impact on our patients and dispo plans. There's impacts on future healthcare utilizations and quality of life, and especially for our older adults to be able to safely age at home. So with that, I'm just going to open up to questions and talk about, open up to if anyone else has any best practices or things that they've been doing in their departments on this topic.
I have a question. I got a question that might be tailored to the attorney member of the panel, perhaps. I recall within the last 1 or 2 years reading an article that was pretty striking in the New Yorker about guardianship, and we're here in Nevada, and I think that was the focus of a lot of the attention of really pretty deplorable cases of people having, marginal, but still seemed like pretty effective functioning and mental capacity, having assigned a guardian and funds removed and drained and real significant disconnection. My take home from that was that that varies a little bit state to state and that there was maybe some improvement in that. But I've in Northwestern seen people, say, hey, my son or my stepson or somebody is trying to get, guardianship of my, my funds, my state, my, ability to self-determine my decision making. And so it seems like an interesting thing. Could you comment on whether this is getting worse, better, solutions? Is this a hot button topic we ought to really be attacking at the emergency department?
Oh, interesting. Great question. I remember that New Yorker piece well, and we actually featured it in an organizational newsletter, and I highly recommend it if any of you check out the archives. I cannot speak with authority to whether the problem's getting worse or better. I can speak to one thing. That article was skewed about what the guardianship problems are in our country. It's very easy and it's frankly sexy to write about really scandalous abuses of power like what this shop did in Nevada, and that's the stuff that makes headlines. What doesn't make, and you're absolutely right, very, very good that you know that, guardianship laws and guardianship resources vary state by state. Nothing about that has changed in the last 2 years, and so it's super state specific. If anything, we have two problems around, yes? Essentially, people were, there was an independent, really for-profit company, as I recall, that was offering to do person-centered guardianship, but really they were just draining people's bank accounts, and it was horrific, with lots of attendant impacts well beyond their bank accounts. Thank you, Alex. So I think the two less visible, less sexy for the New Yorker problems are that, number one, we don't have enough people to serve as guardians for your socially isolated, unbefriended elders who present. So we have a guardianship deficit, and that is only going to be built by political and civic will in different states and communities. And there's actually a lot of policy thinkers who are trying to give thought to how we create frankly, compensated guardianship arrangements that account for the kinds of conflicts of interest that can arise, including in PCA arrangements, right? These are not unfamiliar challenges. The other challenge in guardianship is that sometimes the hospitals and patients disagree about whether they should have a guardian or who that guardian should be. And so conflicts of interest in this realm are exquisite and common. So I just would say, do a very local needs assessment around guardianship before you do anything. That's my advice to you. Make sure you're triaging what the problem really is in affecting the most number of people in your area.
Great. Well, thank you guys for coming.